I have a true confession to make here. You said this morning, Gary, that you don't use the term lean. I don't use the term engineering. So I'm going to talk about value stream improvement with the PDCA, PDSA cycle. And this is simply a reminder, and this is from down in the trenches, trying to work on getting organizational change made and sustained. Some things to remember as you go through this process of trying to improve scheduling. 10 quick and dirty things we've learned the hard way. Lots of effort in lean in healthcare has been in isolated improvements in very small areas. One of the things we know, if you really want to have impact, is you have to link those improvements to processes that matter, to the organization's strategic plan, to its annual goals. But the other piece I want to add to that I've seen in manufacturing operations is that the corollary is you have to communicate that link to where people work. I live 16 miles from the first Toyota plant that was built in North America. And if you go in that plant, you see their strategic plan, their annual plan for the year and all the goals. But as you walk around that plant, every place you go, you'll see not only the goals, but in that unit, what their part of achieving that goal is, what the expectations are, what their current performance is, and there's an opportunity for doing problem solving. So if we're talking scheduling, somehow that scheduling needs to be linked to organizational purpose, and everybody who's working on that needs to know how that links to the top. Another thing that I've learned that can be really helpful is if people are not used to doing this kind of improvement work, start with a win for the people doing the work. And I'm getting ready to quote something that I've never seen in print. It may be an urban myth, but we've probably all heard that doctors and nurses spend 30 to 40% of their day waiting for things or looking for things, right? Anybody heard that before? Anybody experienced that before? There you go. All right, so one of the things we know is if you want people to do the improvement work, we have to address the what's in it for me. And if we can create an opportunity for people to see how they personally will benefit, sometimes that benefit is we can take better care of our patients because we're going to get rid of a third of the looking for things and waiting for things, the flipping through screens. I hate to say that, sitting next to you guys, that doesn't really add any value to our work with patients. Really, really important there. The other corollary to that is the organization, the hospital, the clinic, has to build in capacity for people to do that work. Comes out of people's hides most of the time. They're not given extra time to work on that improvement work. And so we need to find a way to link technical expertise with those people who can do it. I'm not changing my screen. Here we go. I've listed the 10 up front. Pick processes that matter. Start with the win for the people doing the work. Be clear about scope and don't creep. I've done a lot of work in emergency departments, and one of the things we had to decide up front, are we tackling all of the emergency department, or are we tackling, to use the vernacular, treat and street only? And if we're doing treat and street only, are we including from the EMS? Are we including from the time people come in the door? Are we including sexual trauma? Are we drilling? The more, as we start an improvement project, we can be very clear about the scope of that project, reach agreements about it. Where does it start? Where does it end? What's in scope for change? What's out of scope for change? All of those things will be helpful in terms of increasing our chances for success. Next, I borrowed this from business thinking, get the right people on the bus. David talked very powerfully this morning about the importance of getting patients involved in improvement efforts. In our improvement workshops now, we are inviting patients to come and help do the current state mapping and the future state mapping and hoping to engage them in running the experiments for improvements. But when I talk about right people on the bus, I'm talking about the technical experts, but I'm also talking about the people who are the customers and suppliers of that process and the people who do the work in the process. So if I'm working in a cancer center right now where we're doing a Start on Time project. And the people engaged in that project included 4 patients, included 2 physicians, included a number of nurses, included registration personnel, included people from pharmacy who prepare the cancer drugs. So people who are working in the process, who know the process, need to be included. Go and see. The lean people use the phrase go to Gemba. One of the things we ask people to do when we start an improvement effort is to go where the work is being done, even if it's at a computer. Because what you think you are dealing with looking at a spreadsheet is not the same as what you will learn if you go look. In our Start on Time experience at the Cancer Center, as people followed patients through that experience, one of the things they learned about the reason they didn't start on time was because once the patients arrived, people doing registration had 1,000 interruptions. And when we started doing root cause, a lot of those interruptions were related to the discharge process from their previous visit. They didn't know if they were supposed to be there for labs. They had 100 questions and 100 phone calls. So what you think is going on really needs to be validated by a core team of people to go see what's happening. There we go. Eat the elephant one bite at a time, but plan to eat it all. This takes us back to thinking about the systems level approach. I've done some work on patient-centered medical home, trying to get patients enrolled in patient-centered medical home. And as I think about one of our clients, the goal was patient access. Well, that's an elephant goal. And if we start looking at that elephant goal, that starts to break down in things like empanelment. Not only do we have a process for empaneling patients, but do we have an ongoing process for keeping those panels roughly the same size? Getting them empaneled once and keeping them empaneled equitably is not the same thing. Scheduling of patients would be another chunk of that. We're running into problems with scheduling in terms of use of mid-levels. We have physicians who will not use mid-levels. And so starting to peel back, why aren't they using the mid-levels? Well, that gets to geographically where are they located, and do they have any role in hiring the people they're being expected to entrust their patients to? So a lot of this kind of improvement work to me is sort of like those Russian nested dolls. You know, you pull the top one out and there's another one and then there's another. That's, if you think you're going to get this improved, my colleagues at Toyota say, what part of continuous do you not understand about continuous improvement? Okay, we've talked about this a lot today. Count, 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 but count the right things. Every value stream needs to have, I like using the analogy of vital signs. Every value stream needs to have vital signs. For well care for people, we have vital signs that tell us whether we're doing well or not. We need vital signs for our value streams. If I'm thinking emergency department, I'm thinking things like not only length of stay, but I'm looking at patients who left without being seen, patients who left against medical advice, patients who had an unplanned readmission related to their emergency care within 30 days, and patient satisfaction. And I don't want to pick on Press Ganey here, but I would love it if you guys had immediate patient satisfaction scores, not...
You have to talk to CMS about that.
Okay, all right. Okay, now those are our vital sign metrics, and typically we're getting better about having those built into our IT systems. But what I find in the real improvement work is getting the right things counted and doing that in a way that doesn't overburden people with collecting data is a problem. Back to our cancer on start time, when we started looking at interruptions. In order to improve that, we had to know how many times interruptions occurred up front, and then we had to be able to count the nature of the interruptions before we could make improvement. None of that's in the IT systems. So getting people to know what to count and finding a way to make it countable and reliable that doesn't absolutely choke the horse is a real challenge. Okay, I love this one. Experiment before you implement. If we had done that with the Affordable Care Act, when we rolled out the IT enrollment, we would have improved a lot of problems. One of the things I love about lean work is engaging frontline staff in doing small, rapid cycles of learning, small reversible experiments, Organizationally, most organizations make a decision, jump to a plan, implement, and then clean up the mess afterwards. That's not good value stream improvement. We need to run, you guys agree with that?
That's not good engineering.
It's not good engineering. All right. It's not good engineering. We need to be able to break these improvements down and run small experiments on them with the PDSA cycle. Another thing I want to suggest, and this is relatively new to us, don't be afraid to take it outside. And by that I mean cross-function, I mean cross-profession, and I also mean outside the doors of the institution. We've started talking about telemedicine today here. I worked in a mental health project up in Grand Rapids, Michigan last year. And in that project, where we did, by the way, include caregivers, we didn't have any patients involved, but we had caregivers involved. We also had police. We had people from the court system. We had anybody who was involved in mental health in the community engaged in that improvement effort because they were suppliers and they were customers of that process. So don't be afraid to take it outside. The final thing I want to say is make it visual. I've not been to Virginia Mason in, I'm going to say, 30 years. So I don't know what's happening there on this point, but I have been to Theta Cares Hospital in Appleton. It's full of visual boards. People know what's happening, they know how they're doing, and in manufacturing now, beyond simply performance boards, I've been in some lines now where we're starting to use iPads for standard work. You get your standard work printed out on the iPad, you can look up things, you can make rapid changes, but everything's visual, everything's very easy to follow. We talked about the transparency, everything's very transparent. If you can make it fun, even better, but at least not make it painful. I know hospitals that roll out these kinds of big changes with spaghetti suppers and casino nights. So that's all I'm going to say. Thank you.
Thank you.
Oh, one other. I said that's all I'm going to say. That's not all I'm going to say. Let me back up and say one other thing. Two other things. Toyota is sort of the vanguard of lean thinking, but several of my colleagues spent 13 or 14 years at Toyota, and they say it's important for people in healthcare to remember that the techniques that we learn from lean manufacturing are solutions that they develop to their problems. Many of those solutions are not going to apply in healthcare, and we need not to try and make them fit healthcare if they don't. What's important is the thinking, that we have a clear analysis of the problem, we start to look for root causes, we start to test solutions, scientific method, which is not unknown in healthcare. The other thing I want to say about that is I hope, and Peter, you may kick me after this is over, I certainly think best practices are appropriate, but I hope as we get into our improvement efforts, we start to move from the old cancer model where we look at what the research tells us about what treatment fits most people most of the time and move to like the cancer model where we do genetic testing and we customize so that we take what we learn about best practices and know what we need to do to make it fit in the particular environment, physically, resources, the community that we're working with. Because as we've talked today, trying to schedule me for a visit is not the same as trying to schedule my 90-year-old father. He can use an iPad, but he can't use a kiosk to check in, and he hates telephone answering systems. I love them. We're not all the same. That's it. Thank you.
Thank you very much. We have some